Welcome, everyone, to the webinar entitled Considering a Comprehensive Approach for Bronchiectasis Management, Advances in Multimodal Treatment. Hello, I'm Dr. Christopher Richards. I'm a pulmonary and critical care physician at the Massachusetts General Hospital at Harvard University. I co-direct our Bronchiectasis Center, our Cystic Fibrosis Center, and run our division's pulmonary genetics program.
And I'm Patrick Flume. I'm a professor of medicine and pediatrics at the Medical University of South Carolina in Charleston. We have a large bronchiectasis and mycobacterial lung disease program, and I've long been involved in the care of patients with cystic fibrosis.
Our learning objectives today are going to be to summarize the steps that lead to an early and accurate diagnosis of bronchiectasis, recognize the impact of exacerbations on the overall burden for patients with bronchiectasis, describe a comprehensive approach to the management of bronchiectasis that considers the multiple drivers of disease progression, and assess the latest clinical trial results that support a multimodal approach for the treatment of bronchiectasis. For our agenda today, we'll be recognizing and diagnosing bronchiectasis, reviewing the exacerbations in bronchiectasis, the vicious vortex and multimodal care, and recent evidence and current understanding of bronchiectasis treatment approaches.
Recognizing and diagnosing bronchiectasis. Let's start with a patient, and this is an actual patient from our clinic. She is a 61-year-old woman. She has a history of a daily cough productive of yellowish green sputum, and she's been treated with antibiotics 3 times in the last year for an exacerbation of these symptoms with increased cough and increased sputum production. On physical examination, we hear diffuse rhonchi with some squeaks, and there's no digital clubbing. Her spirometry had shown some moderate obstruction with an FEV1 of 62% of predicted, and you can see the chest X-ray that is shown here. We requested a high-resolution CT scan of the chest. And the CT was very informative, helping us see details that we couldn't appreciate with the chest X-ray. Although the chest X-ray was not normal, what you now can see very clearly on the CT is the evidence of bronchiectasis. It's principally bilateral and is anterior in the chest. And so what you can see are the dilation of the airways, as well as some increased airway wall thickness and even some mucus plugging within those airways. CT scan, particularly high-resolution CT scan, which typically is the norm at most centers, is the definitive way to confirm the diagnosis of bronchiectasis. Although you can appreciate bronchiectasis on a chest X-ray, generally it's not sensitive enough and is only going to detect those with very large features of bronchiectasis. So when to suspect bronchiectasis, there are a number of symptoms and signs that should trigger the clinician to request the CT scan. Some of the symptoms that patients will present with include cough, but it's a persistent cough. It's not a cough that's just there with a short-term viral infection, but one that persists for many days, many weeks. If there's persistent sputum production, if they describe breathlessness on exertion, if they have these recurring episodes getting diagnoses of bronchitis or pneumonia, even if the chest X-ray isn't demonstrating features of pneumonia, or when you have patients who you believe they might have asthma or COPD, but they're not responding to usual treatment. These are all clinical features that should suggest possible bronchiectasis. Signs that you may see or other symptoms, on auscultation, you might hear crackles, but these are often absent. Squeaks are typically more common. They may have a history of chronic rhinosinusitis. They may describe symptoms of chest discomfort, fatigue, which is a big one, maybe even some weight loss, kind of like having chronic flu. But you also might be suspicious if they have another underlying disorder, which is often associated with bronchiectasis, for example, rheumatoid arthritis. So these would be easy triggers to lead towards diagnostic testing. So what do we mean by bronchiectasis? Technically, it's really not a diagnosis. It is a condition that can be associated with many different diagnoses. And essentially, it is a dilation of the airways. So bronchiectasis is derived from the Greek terms bronchion, meaning windpipe, and ectasis, meaning stretched. And the way that we calibrate the size of the airway is to compare it to the accompanying artery that travels with it out to the periphery. And in general, the airway should be smaller than that accompanying artery. And when it is at equivalent size or larger, then that meets the criteria for bronchiectasis. There are some challenges in making the diagnosis because these patients present with such heterogeneous features. And technically, it's a condition, and so they may have a number of features rather than just a single component. Some of the features that you might see on a CT scan is in part not merely to make the diagnosis of the bronchiectasis, but to also give you some information about other aspects of it, such as the potential etiology of the bronchiectasis or the sequelae of bronchiectasis. So you can see features on the chest X-ray, and you see in this image the presence of some cystic changes in the upper lobes. You can also see what are described as tram tracks, parallel lines in which the airway is dilated, coming down there in the lower lobes. On the CT scan, you can appreciate those cystic changes that you may see on the chest X-ray. And then on the airway wall, we focus on the thickness of the airway wall. It may not be that the airway itself is thickened, but may be an indication that there is an extra layer of phlegm creating that appearance of airway wall thickness, suggesting that there is an excess material within there. Other features you may see include mucus plugging. So you see this density contained within the airway. And so on the left, you see these cystic changes going out towards the periphery with a dense white material contained within it. That's mucus plugging. But we also look for nodules. And these little nodular densities can be found throughout the lung. They are often now interpreted by the radiologist as evidence of infection with particular interest in mycobacteria. But honestly, you can see these nodules in the setting of recurrent aspiration. So it just is an indicator of increased inflammation, injury, potentially infection. You will sometimes see descriptions of the shape of the bronchiectasis, oftentimes described as cylindrical, but sometimes varicose or cystic. These are not necessarily features that assist you with the etiology or sequelae of infection. They just are different manifestations of the airway remodeling, if you will. When we see bronchiectasis, not all of it is due to airways disease. And so in general, that dilation of the airway is either because of an extrinsic pulling on the airway, which is what you can see here in the setting of interstitial lung disease, or we call it a traction bronchiectasis. But the challenge there is that is not necessarily because of inflammatory changes or other infectious etiology within the airway. The problem there is in the parenchyma of the lung. Whereas other types of bronchiectasis, they are the result of an intrinsic abnormality within the airway. The prevalence of bronchiectasis is on the rise. What you can see on the left were data from preceding 2001, and what you could see is that the prevalence of bronchiectasis was increasing by age group. But when you now look at the data that are a little bit more current, so these were the estimated prevalence in 2013 on the right, you can see that the prevalence per 100,000 subjects is much, much greater than it had been recorded in 2001. We continue to see the increased prevalence with age, and we also see an increased prevalence in women compared to men. Now, why is the prevalence increasing? In part, this could be because the incidence of disease is actually increasing. Its association with certain other conditions may increase the number of people that could develop the condition, but also is because of increased awareness and an increase in the use of CT scanning to identify patients who otherwise would not have been identified previously. Again, some more data showing that the bronchiectasis prevalence is increasing in the US. And so you can see in the figure on the right that the numbers are increasing to the tune of about 8.7% annual increase prevalence in the Medicare population. And again, that there is a greater prevalence in the women compared to the men. It's 36% more common in women than in males. So we're talking about affecting somewhere between 350 to 500,000 adults in the US. So there's one patient with bronchiectasis for every 20 with COPD in Western countries. So it's becoming increasingly common. We also have a population of patients with cystic fibrosis whose principal pulmonary manifestation is bronchiectasis, and that number is increasing over time as well. There's a lot of heterogeneity in the disease. You can have airway size, which ranges from just a little bit greater than normal to quite large dilated airways that anybody is going to recognize. But the disease can also be very focal, or it can be more diffuse, affecting more lobes of the lung. And this can be some useful information to help you try to understand the etiology of the condition. The list of conditions that either are known to cause bronchiectasis or associate with it is actually quite long. And you could spend an awful lot of money looking for very specific diagnoses, many of which you can't actually have a specific therapy for. So when you think about planning for testing to try to determine the etiology, you can go to the image to try to help with that. So for example, patients who have focal disease, it may be because they had a bad infection in their history that didn't heal completely, and now they're left with some residual airways disease. And this would be something that can be seen in a previous mycobacterial infection, such as with tuberculosis. But in the past, there were patients who had bad measles infections or a bad bacterial infection that left them with some residual changes. Or you may have an airway obstruction, for example, with a foreign body or a stricture of an airway, an obstructing mass that's including that airway, causing distal abnormalities. If a patient has more diffuse disease that's affecting multiple lobes, then you've got to start thinking of conditions that can affect all parts of the body. Again, sometimes seeing it in post-infection, but now congenital syndromes, for example, with cystic fibrosis or ciliary dyskinesias, immunodeficiency states, so people have a deficiency of immunoglobulin or a history of HIV/AIDS, but also autoimmune disease, in which the airway is one of the targets. So you can see this in things like Sjogren's syndrome or rheumatoid arthritis. We see it with some frequency in patients with inflammatory bowel disease. And then there also is the condition of allergic asthma. Allergic bronchopulmonary aspergillosis in particular has been well described as having bronchiectasis as one of its features. And then probably one of the most common etiologies is recurrent aspiration, oftentimes in the presence of gastroesophageal reflux disease. And you typically will see these changes in the lower lobes in patients who have other features to suggest reflux. The clinical diagnosis of bronchiectasis, as I said earlier, is to get a high-resolution CT scan of the chest, and that helps you confirm the diagnosis. And that leaves you with then two essential questions. Why do they have this diagnosis? And then what are you going to do about it? And so to answer the first question, there may be further testing to try to get at the etiology. So again, looking at the images we just discussed, and then you might consider assessment for other underlying diseases. But keep in mind that in nearly half the cases, an underlying cause will not be identified, even if you do extensive testing. Now, although we tend to use the term idiopathic, that generally is not a very satisfying diagnosis. Then there is testing to try and understand the sequelae of the bronchiectasis. What are the complications that patients are having as a result of that? So some basic testing looking at the microbiology, so getting respiratory cultures to understand whether there is persistent infection in the lower airways that might influence your management. Pulmonary function testing to look at the severity of impairment on their functional status would be advised.
So exacerbations in bronchiectasis. So what are the goals of disease management? Well, first and foremost, it's to relieve symptoms that our patients present with, whether those are symptoms of cough, shortness of breath, dyspnea, hemoptysis, fatigue. Those are the things that we're aiming to improve for our patients through the prescribed therapies. We want to prevent and minimize the progression of the disease. We want to also prevent, minimize the complications of the condition, including exacerbations. And those complications we'll get into further detail later on, but they can be quite varied. And again, what we're really trying to do for all of our patients is to improve their quality of life. We can't have any conversation about exacerbations without first defining that what an exacerbation is. I think it's worth noting that what an exacerbation is may differ based on whom you're speaking to. Are you speaking to other physicians or are you speaking to the patient? So from an academic standpoint, we tend to derive our definition of an exacerbation based on what is the qualifications for one in a clinical trial. And in that setting, we're generally looking for a deterioration in 3 or more key symptoms that are lasting for more than 48 hours. Cough, sputum volume or consistency, increased purulence of sputum or change in its color, increasing breathlessness, decreasing exercise tolerance, fatigue, malaise, and hemoptysis. You take those and then you combine that with the physician agreement that these constitute an exacerbation and that a change in treatment is needed, and that's how we define it in clinical trials. In the real world setting, though, we're going to be hard pressed to be able to succinctly gather that information from our patients to say, yes, my cough worsened for the last 48 hours. And well, my sputum was started green, then it turned white, but now it's green again. There's a lot more at play. There's a lot more variability in what a patient out there in our clinics is going to be able to report to us. So for a patient, more often than not, that definition is a change in their respiratory symptoms, their baseline respiratory symptoms, that is significant enough for them to come and seek care. And we may wind up utilizing now and in the future these novel patient-focused exacerbation diaries. So patients can take a 30,000-foot view, step away from their daily symptoms and recognize, oh, there has been a change over time. One of the things with this definition you have to be very careful about is you have to make it welcoming and inviting for the patients to call you if they're worried they have symptoms. The worst you can say is, no, I don't think we need to treat right now. But if they never call, you'll never know. And exacerbations can go unmissed or be prolonged before they're ever treated. How common are exacerbations in people with bronchiectasis? The answer is quite common. Looking at insurance claims data, you can see that in a year following the initial assessment, that about 35% of patients will have no exacerbations, but another 20% will have had one. And actually, there's a fair number of patients who have, 30% will have 3 or more exacerbations. If you go out 2 years from the initial period, that proportion of people who have had one exacerbation drops from 30 to 25%. And then those having more than 3 increases from about 30% to 46%. So one of the things to recognize here is that the people who exacerbate more frequently will tend to go on to have more frequent exacerbations. And it seems to be a problem that compounds on itself. And on average, the people in these studies will have had about 3 exacerbations per year. Exacerbations also have a clearly negative impact on one's quality of life, with those patients who have a higher number of baseline symptoms and a higher number of exacerbations per year being correlated with poor overall quality of life scores. The other thing that we know is those patients who have a higher exacerbation frequency have lower lung function, And while that lung function may not change year to year, that still having an FEV1 below 70% is correlated with having at least 2 or more exacerbations per year. Frequent exacerbations are also associated with poorer clinical outcomes. So patients who have more than 3 exacerbations per year tend to be hospitalized almost twice as frequently as those with 2 exacerbations, and about 4 times as frequently as those with 1 or 0 exacerbations. The other thing that we know is that for those patients who have 3 or more exacerbations per year, their predicted survival drops much faster than the patients in the other 3 cohorts.
Now I would like to talk a little bit about our understanding of the pathogenesis of bronchiectasis and how this influences our current methods of care. And the term that we are typically using is the vicious vortex, describing the pathogenesis of bronchiectasis. Historically, there had been a model describing this vicious cycle of disease that was the cause of bronchiectasis and its progression. And you could start anywhere in that cycle, such as you have ciliary abnormalities, which then leads to mucus retention, which then becomes a ripe environment for infection, and then an inflammatory response, which causes injury to the airway, and then subsequent greater impairment in mucociliary clearance. But what we've learned is that each of those parts of the pathway don't merely just affect the next part of the cycle, but actually has an influence on every part of that cycle. So when you have mucus hypersecretion and impaired mucociliary clearance, so you have a dysfunctional clearance of secretions, that not only creates a retention of the mucus, causing some airway obstruction and a ripe environment for which bacteria could establish a presence, but that excess mucus also triggers an inflammatory response, which then also can cause airway destruction and create greater potential for inflammatory milieu in which infection can then thrive. And so each of these is contributing to the other. And so it's really more of a vortex. And so it's not, when you think about therapy, it's not merely to try and block one aspect of the pathway, but you've got to think of each of these different parts of this cycle, this vortex, that which you could try to interrupt the condition and see if you can improve the patient's health. So there's opportunities for treatment. When you have airway dysfunction and you have mucus retention causing obstruction, this is where airway clearance therapies can be very, very useful. So the basic premise is to remove this mucus, this phlegm, from out of the airway. And what I often tell patients is every drop of that sputum that they cough up contains millions of bacteria and lots of inflammatory mediators. So clearing that stuff out does a lot to reduce what's happening down in the lower airways. These airway clearance therapies we generally describe as breathing techniques or the use of devices for the purpose of clearing out phlegm. But we also will use hypertonic saline as a means of trying to augment that process by hydrating those secretions and actually causing cough to help with the clearance. If we're talking about inflammation, we actually have had not very many available options to us. And one of the therapies that has been purported to address the inflammation are the use of chronic macrolides. Now, there is no doubt that chronic macrolides have a proven benefit as part of the management of bronchiectasis. And people have argued that has anti-inflammatory properties that they believe may be contributing to that. But we have to accept that it's also an antibiotic. And so how that fits into the model is not entirely clear. And then when we're dealing with infection, we can, on the one hand, try to eradicate the infection. In some cases, that's not possible. And so we can try to suppress that infection, knock down the bacterial load, which may then result in a reduction in the inflammatory response. And in the airways, we have the luxury of being able to provide antibiotics by two different pathways. One is by systemic delivery, whether it's by intravenous or oral treatment, but we also can use topical antibiotics by aerosolizing or using inhaled antibiotic preparations to try to get to the airways more directly. So when you look at the guidelines approach, and keep in mind that most of these therapies do not have a labeled indication for the treatment of bronchiectasis. So many of the things that we do are off-label use of these therapies. So when we're talking about the impaired mucociliary clearance, we use multiple different modalities for airway clearance. We have many choices. There is not one that is preferred. All are generally effective, but you need to find the one that is most preferred and will be used by the patient. And we use therapies like hypertonic saline. For structural lung disease, the bronchodilators might be of help if they have asthmatic features, but in general, in bronchiectasis, they are not terribly helpful. Certainly, pulmonary rehabilitation can be quite useful for their functional status, and in very select cases, a surgical option might be of consideration if they have very focal disease. On the inflammatory side, long-term anti-inflammatory therapies, we're typically talking about the chronic macrolides. In general, steroids do not have a role in bronchiectasis unless they have special features that look like asthma, and particularly with elevated eosinophil counts. And then with chronic bronchial infection, we have the choices of using antibiotics to try to eradicate infection. Generally, this is a very difficult thing to do because we don't necessarily know how long the infection has been persistent, and once fully established, might be more difficult to eradicate. We have been using long-term inhaled therapies for organisms such as Pseudomonas. In cases where staph might be the culprit, especially MRSA, there are situations in which oral antibiotic therapy has been effective. And of course, we use antibiotics for the treatment of exacerbations. So getting back to the airway clearance methods, the rationale is pretty straightforward. Get this stuff out because it will, in some cases, open up an airway, and so get better airflow within that. But it also is a way of reducing bacterial load and inflammatory mediators. There are a number of therapies that are available. Some involve just breathing techniques, such as with active cycle breathing or the forced expiratory technique or autogenic drainage. And some involve the use of devices, some of which are relatively inexpensive and portable, and others which can be rather expensive, but if they are effective, maybe money well spent. And so it is wise to have engagement with a respiratory therapist who's skilled in the education of these different methods to try to find the one that works the best for that particular patient. For antibiotic use, obviously, when a patient comes in more acutely ill, we have an inclination to try to knock down the infection, either because we believe that that bacterium was the culprit in causing the problems or something else aggravated it, and now they have this sort of bacteria gone wild to try to see about how to try to suppress that. And so when patients come in with persistent symptoms over at least a few days, then we try to select antibiotics that would be appropriate for that particular patient. This is why it's very helpful to get surveillance cultures on our patients to have some knowledge about whether there are bacteria that persist in the lower airways. So, for example, if you know that your patient grows an organism like Haemophilus influenza, that would be the target. And with that, you could use penicillins or other agents that might target that well. If they grow Pseudomonas, then you definitely want to try to target that as your pathogen of interest, and your choices might be more limited. Now, in terms of antibiotic use, people will often label the use of IV antibiotics as representative of a more serious exacerbation, but that is not always the case. In some situations, it might be because you have such few choices. So, for example, with Pseudomonas, if your patient is either unresponsive or unable to tolerate fluoroquinolones, there are no other oral agents that would target Pseudomonas, and so you would need to go to intravenous therapy. And so thinking about the choices there, you just have to tailor it to what you believe the patient may have. Now, viral infections are often implicated as an exacerbating feature of bronchiectasis. And the reason for that is because in studies of exacerbations, you frequently find viruses present on testing. A limitation to that is we never really test people when they're well to find out how often we might find viruses. And there are a couple of papers that have demonstrated that to be the case. Nonetheless, it is not hard to believe that a viral infection could be a triggering event. And although antibiotics may not do anything about that viral infection, they will sometimes be used because of the belief that the bacterial infection that's already present has become worse and we need to try to calm down the inflammation. The duration of antibiotics is generally recommended to be 14 days. We have recent evidence from the cystic fibrosis population that 14 days was the most effective duration, except in those much milder cases. So 14 days is the recommended treatment duration. What about the long-term therapy with inhaled antibiotics? These are typically used for those patients who are having recurring exacerbations. So you might not be able to eradicate the infection, so you're just trying to suppress this. We have greater data in patients who have Pseudomonas aeruginosa as their persistent infection. There are none of these that have been given the label for the treatment of bronchiectasis, with the exception of cystic fibrosis, where tobramycin or aztreonam are approved products. But we have a lot of clinical experience using them in appropriately selected patients. And again, these are patients who have frequent exacerbations. It makes sense to use those products that have been formulated specifically for the airways, such as with tobramycin or aztreonam, but there are other antibiotics in which the IV formulations have been used with success. Chronic macrolide therapy is also an option for those patients who are having recurring exacerbations. And there is clear evidence of the benefit of macrolide therapy in these patients, and shown in the figure is just but one example, looking at the time to exacerbation in patients with bronchiectasis. And you can see in those who were treated with placebo, their time to exacerbation was much shorter than in those with chronic azithromycin. The challenges with chronic macrolide therapy is selecting out the right population. So again, the indication is frequent exacerbations. It's a little bit more effective in those who have Pseudomonas present in the airways. But you've got to be careful in this patient population, particularly because they're older. They may be on other medications that may interact with the macrolides. They may have hearing issues, and so you need to think about tinnitus or hearing loss. And they may be on medications that already are affecting QTC prolongation, and so you may need to monitor for that. There are concerns that people have about chronic macrolides in this population, primarily because it is one of our best agents for the treatment of mycobacterial infections, and we generally do not recommend monotherapy of a macrolide against a mycobacterium. So it is very important to get cultures for mycobacteria in patients in whom you may be interested in using macrolides to be sure that they don't have them before you start them. And then it's wise to monitor cultures over time, because you don't want to have them acquire a mycobacterial infection. And in those settings, we typically will stop the macrolide therapy. Again, the mechanism of action is not as well understood. There are a number of features about the macrolides that have suggested it has an anti-inflammatory effect, but again, it is an antibiotic, and there may be organisms which are not easily cultured. Nonetheless, macrolide therapy is a very effective approach in these patients.
Recent evidence and current understanding of bronchiectasis treatment approaches. So one of the things that we've learned in the last several years about bronchiectasis is that neutrophils play an essential role in the specific types of inflammation that are occurring in patients with bronchiectasis. We know that the higher the neutrophil numbers or markers of neutrophil activity, like neutrophil elastase, they correlate with the bacterial loads that we may wind up culturing from our patients. While neutrophilic inflammation is the majority form of inflammation amongst patients with bronchiectasis, there is a smaller but very important subset of patients whose inflammatory response tends towards the eosinophilic. And that can be upwards of 20% of patients with bronchiectasis will have some sort of peripheral eosinophilia, a number north of 300 cells per microliter. There is associated with that a Th2 inflammation that we may see very similar to that in ABPA or in asthma. And the thing is that this eosinophilic inflammation can be coexistent with the neutrophilic inflammation. But the treatment of eosinophilic disease does differ significantly from the treatment of neutrophilic inflammation. So in these instances, it may be situations where we do offer an inhaled corticosteroid for an eosinophilic phenotyped patient, whereas with a neutrophilic patient, that inhaled corticosteroid may not be of as much value. We may also find that patients have high peripheral eosinophils. Maybe they have high eosinophils on bronchial alveolar lavage, and there may wind up being rationale for treating them with either systemic steroids or, more ideally, anti-IL-5 or other forms of biologic maintenance, just as we would someone with severe fungal sensitized asthma or ABPA. So again, at the heart of the inflammatory response in bronchiectasis is the neutrophil, and not just the neutrophil itself, but one of its proteases, neutrophil elastase. And that's neutrophil elastase, the response of the airway to high concentrations of this protein, this enzyme, result in increased mucin expression, impaired ciliary mobility. There may be interrupted or defective epithelial repair. There may be chronically activated inflammation and also impaired innate immune function. So therapies for bronchiectasis, successful therapies for bronchiectasis may well wind up targeting these these elastases and other neutrophil proteases. So one of these approaches to reduce neutrophil elastase is through the inhibition of dipeptidyl peptidase 1 or DPP1. The way this enzyme works is that it activates these neutrophil serine proteases as the neutrophils are being matured in the bone marrow. By blocking these proteases, the idea is that you'll get a less constituently activated inflammatory response later on in the lung tissue. So there are different inhibitors for DPP1 that have been discovered and that are being developed for clinical use. So there has already been one phase 2 study of a DPP1 inhibitor known as brensocatib. These data as part of the WILLOW study. And within that, it was about 256 adult patients who were randomized to either receive 10 milligrams, 25 milligrams, or placebo dosing of this novel inhibitor. Patients had to be those with frequent exacerbations, so had to have at least two or more exacerbations a year following that clinical trial definition we discussed earlier, and had to be having a daily cough with sputum production. So in this phase 2 trial, by measuring sputum neutrophil elastase, so a biomarker of the drug's action, there was a notable significant decrease in the concentrations of neutrophil elastase by week 4 of follow-up, persisted until the drug was held at week 24, and then returned to the baseline seen in the placebo by 28 weeks. Phase 3 study subsequently been performed and concluded with the presentation of the data at the 7th Annual World Bronchiectasis Conference earlier in 2024. So in this study, the phase 3 study, it was about 1,700 patients with non-CF bronchiectasis who again had 2 or more exacerbations in the 12-month prior to screening, were randomized to receive either 10 or 25 milligrams of brensocatib or placebo, with a primary endpoint being the annualized rate of pulmonary exacerbations over a 52-week period. Secondary endpoints included the time to first exacerbation, proportion of patients who remained exacerbation-free, the change in the post-bronchodilator FEV1 at 52 weeks, the rate of severe exacerbations, and any change in respiratory symptoms. For as far as the primary endpoint of the study, the annual rate of pulmonary exacerbations, there was, as compared to placebo, just about a 20% risk reduction for both the 10 milligram and the 25 milligram arms. The absolute reduction there was about 1.3 exacerbations per year in the placebo and down to about 1 exacerbation per year in each of the treatment arms. As far as the secondary endpoints and safety data, 40% of the patients receiving placebo remained exacerbation-free at the end of the study. That compared to 48.5% for those with either dose of brensocatib. There was also a significantly reduced rate of decline of the FEV1 at week 52 with 25 milligrams of brensocatib versus the placebo. There was also improved symptom scores and quality of life with the 25 milligram dosing, and the drug was felt to be both safe and well tolerated at both doses.
I want to come back to the patient case in which this all started. You will recall that her symptoms of recurring infections, frequent antibiotics, abnormalities on exam, obstructive airways disease. We got the CT of the chest demonstrating bronchiectasis, and so we got cultures on her. And the cultures grew both Pseudomonas aeruginosa as well as Mycobacterium avium complex. So how do we proceed with this particular patient? And I want to come back to what we learned from imaging and how we use that to guide our therapies. So for example, we talked about airway clearance therapies and the use of hypertonic saline. So in most of these patients, clearance of phlegm from the airways is job number 1. And so the decision about whether to implement these therapies is basically dependent upon their symptoms. Are they having cough? Are they producing sputum? As well as the imaging to demonstrate whether there is likely to be retained mucus, to have abnormal phlegm within the airways. And so when we see increased airway wall thickness, whether it's in those cystic changes or in the airways themselves, or mucus plugging, then that's when airway clearance and hypertonic saline are absolutely necessary. What about the role of macrolides or suppressive antibiotics, such as inhaled antibiotics? Well, as I said earlier, these were based upon trying to reduce the frequency of exacerbations. So you're not considering these therapies in patients who are otherwise pretty well, in which they have an occasional exacerbations or maybe even very mild symptoms overall. But in those patients who are having recurring exacerbations, now we go to the imaging to try and look for what's the evidence that there might be organisms that would either be an indication for that therapy or a contraindication. So if you see nodular disease, you should be suspicious that you might have infection, and it could be mycobacteria. So it would behoove you to know what those organisms might be before pulling the trigger on macrolides. And you'd want to have evidence of Pseudomonas before you begin a suppressive approach that you believe to be targeting that pathogen. And also, as mentioned earlier, in general for bronchiectasis, bronchodilators and corticosteroids are not recommended, except in those patients who have asthmatic features, and especially in those patients who have what looks like allergic bronchopulmonary aspergillosis. So when on the imaging you see central bronchiectasis, you see large airways with big mucus plugging contained within them, you should have a very strong suspicion for ABPA and check IgE and aspergillus antibodies. And if you find convincing evidence for that diagnosis, then that would dictate therapy that would be appropriate. So the answers that I hope you chose were A, B, and C. So she clearly has increased airway surface mucus retention. She has mucus plugging. So airway clearance therapies are indicated. I also would use hypertonic saline in this patient. In general, we want to be careful with the hypertonic saline, although most patients will tolerate this without any difficulty. Some are going to not enjoy it, and they're going to have increased cough or even chest tightness as if they're having some bronchospasm. Although we have sometimes used concentrations up to 7%, that comes from the cystic fibrosis literature. My experience is that many of my bronchiectasis patients cannot tolerate that, and so we typically start with 3% and consider increasing to 7% in select patients. And because she was having increased symptoms and we identified pathogens, antibiotics targeting that current infection would be appropriate. So in this particular patient, we had a bacterium that was a reasonable target to treat, and we could focus on that. She also grew MAC, which is a different story, and I wouldn't pull the trigger on that just based upon one positive culture. But in terms of the other choices, in her case, chronic macrolides would not be appropriate primarily because of the presence of MAC. Although she has the history of frequent exacerbations, that is not going to be an indication because of the MAC presence. And then, yes, we could use bronchodilators in this patient with obstructive airways disease, and I would be looking to see if she had a symptomatic response or a change in lung function. And she had not given us any indication for the use of corticosteroids. So that's what we did. We started on airway clearance therapy. She didn't find it to be too cumbersome. She feels a little bit better, and we believe that she's pretty adherent to that. We gave her initial treatment with a non-macrolide antibiotic. The infection seemed to clear up. She felt good for about a month, but then she began to feel fatigued and progressively worse. And so she's testing positive again. Choosing any of these from the list, and essentially all of them would be considered appropriate with the exception of corticosteroids. Again, sticking with the airway clearance therapies, hypertonic saline, those would be appropriate. The antibiotic course for current infection, again, you're trying to get her feeling better in the short term, but we have to now start thinking about long-term management. Now, chronic macrolides are a problem in this case because of MAC. In general, if you get repeated cultures and you can demonstrate that we're not having mycobacteria present over a longer duration, and what that duration is not clear, but perhaps it would be a couple of years, then perhaps you might come back in with chronic macrolide as monotherapy. But if you want to use the macrolide, now I think you're then going to have to consider whether you're treating the mycobacterial infection, which would be more than one agent. Suppressive antibiotics would become another option, whether by inhaled or oral route with a non-macrolide antibiotic to see if perhaps you can get some suppression of the infection, and certainly the inhaled bronchodilators. I'm still not convinced that she has met the criteria for corticosteroids. If we did not see an elevated IgE, she doesn't have features to suggest ABPA, so I don't think corticosteroids would be the right answer. The antibiotics for home use, this is a challenge, and some physicians in certain select patients who they feel they can trust will have antibiotics on hand for patients to be able to initiate therapy earlier, but I generally would only recommend this in someone who can communicate well with you so that they're not using them inappropriately. Assessment for reflux and aspiration. I think this is highly appropriate. The prevalence of reflux in this population is exceedingly high and may be one of the exacerbating features. Now, treating reflux with acid suppression is appropriate in people who have symptoms like heartburn or vocal cord abnormalities, but it doesn't stop reflux. It actually just changes the nature of the reflux aid. So if you believe the acid component is the problem, it might be effective, but you really have to focus on factors that might reduce the chance of esophageal reflux, which includes positional changes, changes to their diet, with a particular attention on their caffeine intake. Assessment for other underlying conditions, again, going back to testing for etiologies of bronchiectasis, so looking for things like elevated IgEs or eosinophils, antibody levels, and the like is not unreasonable. Nutritional assessment and counseling. Nutrition is terribly important in these patients, and you've got to make sure that they maintain a good nutritional health. And then self-monitoring for exacerbation recognition. This is really just trying to help them understand what factors they should be looking at and when to contact for help. Up to this time, we haven't really had great options for addressing inflammation in bronchiectasis, again, with the caveats about chronic macrolide therapy. We do use them. Whether it's really treating inflammation is a different question. There has been a lot of interest in trying to find effective ways at dealing with the inflammatory changes. And so our understanding of the role of the neutrophil and excessive quantities of neutrophil elastase, as well as our recent knowledge about the presence of eosinophils and what role they may be playing, has opened up a whole new opportunity for us moving forward. And so we have the recent clinical trial data of a novel approach to treating inflammation, which may give us, if approved, another weapon in our armamentarium to dealing with the challenges that patients face with dealing with bronchiectasis. And as we begin to understand more about the appropriate indications of some of these approved therapies in patients who have eosinophilic disease, may also become highly relevant. And so I'm happy that we now have learned enough to be able to now rewrite the next chapter for these patients with bronchiectasis and hopefully improving their quality of life. And I look forward to the next range of studies to advance our knowledge further. So I hope that this lecture gave you a better understanding of where we are in our knowledge of bronchiectasis. And if I were to leave you with just a few of the key takeaways, the first is trying to make the appropriate diagnosis of your patient. And so in that case, I have a low threshold. I recommend a low threshold for getting CT imaging in patients who have clinical features suspicious of the diagnosis. That is the most important step. Many of our patients still will go a very long time before they get a diagnosis. The second point is this is a very difficult diagnosis for patients to digest. It's these foreign terms like bronchiectasis and Pseudomonas and mycobacteria. And so there is an increase in the number of centers who specialize in the care of patients with bronchiectasis. And so I would reach out to them to learn more about materials that might be appropriate for your patient, possibly referring those patients for further evaluation to try and relieve those anxieties. Third is it's not uncommon for patients that are referred to us where they tell us that the physicians have no other treatment options, and yet, in our view, many options have not even been tried. And so effective airway clearance, the use of inhaled agents like hypertonic saline, appropriate use of chronic suppressive medications like macrolides or inhaled antibiotics, they're not for everybody. They really need to be in the proper use. And then finally, clinical research is terribly important in order for us to learn ways to take care of these patients. So staying on top of what trials are ongoing, encouraging patients to participate in those trials, those are how we're going to learn more and eventually have effective therapies for all of our patients. So thank you.